Everyone, today we are going to discuss diabetic ketoacidosis. Diabetic ketoacidosis, also commonly known as DKA, it is a life-threatening complication of type 1 diabetes mellitus. Yes, it is seen in diabetes type 1 rather than type 2, and mostly it is seen in children, right? So before starting it, we should know a basic pathogenesis behind it. That is, there is absolute deficiency of insulin with or without an increase in the counter regulatory hormones. That leads to hyperglycemia, metabolic acidosis, ketonemia, and dehydration. Now coming on to definition and classification of DKA. First of all, how do you classify DKA? Right? So DKA, the name has it all, right? D for diabetes. So the first definition point is hyperglycemia, serum glucose of more than 200. The second is ketoacidosis. So acidosis, that is defined by blood pH less than 7.3 and serum bicarb less than 15 milligrams per liter, right? Then comes ketonemia. Ketonemia, the measurement of ketones in the blood are not readily available, so we use ketonuria as a marker for ketonemia. Okay, so when measured, ketonemia, that is the ketone bodies in the blood, the major ketone bodies in the blood are beta hydroxybutyric acid and acetoacetate. Ketonemia is labeled when these ketone bodies are more than 31 milligram per deciliter. Okay, and ketonuria is labeled when the ketone bodies are more than 80 milligram per deciliter. Now coming on to the severity of decay. The DKA is classified into mild decay, moderate decay, and severe decay. We call it mild when the venous pH is 7.2 to 7.3. The serum bicarb levels are 10 to 15 milligrams per liter. Moderate decay is labeled when the child's venous blood glucose blood pH level is 7.1 to 7.2 and the bicarb levels are 5 to 10 milligrams per liter. We call it as severe decay when the pH is very low, less than 7.1, and the bicarb is less than 5 milligrams per liter. Now coming on to the presentation of the baby, the clinical feature. Typically the child presents to us with the history of polyuria, polydipsia. Although the child will be dehydrated, there will be a significant weight loss. The child would be breathing rapidly and shallow, that is known as Kussmaul's breathing, and in his breath there would be a fruity odor, that is due to ketosis, right? So the child sometimes mimic that of pneumonia, asthma, bronchiolitis, or acute abdomen, but with typical history like this, there should be a high index of suspicion for diabetes. Okay, so now when the child presents to us with DKA, history is very important to come to a suspicion that the child might be having diabetes rather than having pneumonia or asthma or bronchiolitis or acute abdomen, right? So typically the child would have a history of polyuria, polydipsia, there would be a history of weight loss, nausea, vomiting, and abdominal pain. Also, if the child is having headache, restlessness, irritability, lethargy, altered sensorium, or loss of consciousness. These are the very dangerous signs because they indicate that the child has developed a very serious complication of diabetic ketoacidosis, that is cerebral edema. Okay, last but not the least, there may be fever that indicates a concomitant infection, and most of the time what happens is this infection only triggers the DKA like situation. Now coming on to the past history. The past history of the child, he or she may be a known case of type 1 diabetes, or they may be a newly diagnosed one with some history of infection or illness or some stress factor, right? So mostly these are known case of diabetic mellitus that have either changed the insulin dosage or regimen, may be poorly compliant to the therapy, may have a past history of episodes of DKA. The presence of previous multiple episodes of DKA also predisposes the child to develop even more episodes in the future. Okay, or insulin discontinuation may be one of the causes. Now, what are the comorbidities that are associated with DKA? As I told you, that any form of stress, infection, trigger, any form of insult could trigger this, right? So the comorbidity will include any recent surgery that has happened, any psychosocial stress that the child is being through, any concomitant infection. Also in adolescent girls and certain social setting, the child may be suffering from some eating disorder, right? And that would also behave like a comorbidity in a child with type 1 diabetes mellitus. Now coming on to the examination of the child, obviously due to the increased number of ketones, the breath would be very fruity, the child will be tachycardic, have low pulses, hypotensive, there will be impaired skin turgor, sunken eyes, delayed CRT, absence of tears, and weight loss. Okay, so all these things indicate dehydration and hypovolemia, right? Because of the acidosis, there would be Kussmaul's respiration for the rapid washout of O2, right? That would compensate the metabolic acidosis. Also, you have to be very cautious that there is any change in the sensorium, any bradycardia or hypertension, as these are the signs of raised ICP, any papilledema, any abnormal pupillary reflex or cranial nerve palsies, again sign of raised ICP. Or if there is certain posturing, this posturing can be both decerebrate or decorticate, right? So now a question comes is, do we admit each and every case of DKA that presents to us in the emergency? The answer is no. We don't admit every case that present to us in emergency. Which all we do not admit are the ones with very mild acidosis, who have no dehydration, and who are able to take foods orally. Okay. Now, what is the indication for taking the child to ICU? Obviously, the ones with severe DK would require ICU admission. Also, the children who are at increased risk of developing cerebral edema, like children less than 5 years of age and those with new onset diabetes, they are at a higher risk of developing cerebral edema, so they should also get an ICU admission. Okay. Now we all know this is a simple basic physiology concept. We know that there is a single anabolic hormone in a body, that is insulin, and rest other catecholamines, glucagon, growth hormone, cortisol, all these are catabolic hormones, and there is usually a balance between these two. I'm making a seesaw to indicate the balance, right? What happens in DK or type 1 diabetes is that there is relative or absolute deficiency of insulin, right? In type 1 there is decreased production, and in type 2 there is peripheral resistance. So this is absolute deficiency, this is relative deficiency, right? With or without the increase in the counter regulatory hormones. Okay, so as I told you, some infection, stress may trigger it. So in response to any stress, that could be in the form of infection, trauma, or surgery, what would it set? It will make the seesaw go down on the anabolic side due to relative or absolute deficiency of the insulin, and the catabolism would go up. Due to this increase in the catabolism, there would be increased glucose production, and there will be impaired glucose utilization because of the insulin deficiency. Also, that will lead to hyperglycemia, hyperosmolality, because we all know that the osmolality is equal to glucose by 18 plus 1, right? So glucose contributes to osmolality, right? So increase in the glucose would also increase in the osmolality. Obviously, as soon as the hyperglycemia crosses the renal threshold, there will be glycosuria, and presence of glucose in the urine would obviously cause osmotic diuresis. Okay. The important thing is, due to the insulin deficiency, the tissues are not able to utilize the glucose, but in the blood there is too high glucose, right? So what happens, there is lipolysis and ketone production, as the cells are not able to utilize the glucose that is present in the environment. Okay, now coming to the management of decay. The management of decay is very critical, and also if done with if done cautiously with all the precautions, it can work wonders for the child. So coming on to the management of decay. First of all, what are the goals of the management of decay? First of all, we have to correct the dehydration in the child. Then we have to correct the acidosis and reversal of the ketones. We have to restore the blood glucose to near normal by then. We have to avoid any sort of complication of the therapy, particularly cerebral edema. Also, identifying and treating the precipitous event that has caused this decay episode. And lastly, preventing the recurrent episodes. Okay. There are certain key points that you have to remember. If the child is hypotensive, you have to do immediate fluid resuscitation in the form of boluses. It is preferred that you give certain isotonic solutions like 0.9% NS, 10 to 20 ml per kg bolus. Also, as this is an emergency situation, 2 large bore peripheral IV lines should be secured, and these should be heparin locked. Whenever we consider the child to be in a severe decay state, we assume that the child has lost 7 to 10% of the weight. Okay, so if there is hypotension or low volume or impalpable pulses, These all indicate severe dehydration. In case of severe dehydration, the weight loss will be more than 10%. Now, as soon as the child presents to us, we send over certain investigations that are very critical to the further management. Okay, so first of all, you look at the serum glucose, either by your lab values or either by that prick method, capillary glucose. Then you have to look for the serum electrolytes. These include sodium, potassium, calcium, magnesium, and phosphate. Then you do a VBG or ABG to look for the pH, CO2, and bicarb values, on the basis of which we will decide whether the child is in mild category, moderate category, or severe category. And finally, lactate to depict if there is increased lactate, then it might go to the septic picture. Base deficit to look for the iron gap, whether it is a metabolic acidosis or there is some other acid-base disorder superimposed on it, right? Also, because of hypovolemia, there is hypoperfusion of the kidneys that can lead to pre-renal failure. That's why blood urea, creatinine, hematocrit, and CBC with DLC is very important. We check the ketones in the urine by a dipstick method and also obtain a baseline ECG so that we can assess changes in the ECG due to hyper or hypokalemia. Okay, it is a very important thing to notice here that degree of hypoglycemia is directly proportional to the severity of dehydration. So if the blood glucose levels are very high, it is a very high possibility that the dehydration will be more and more severe. Okay, so quoting some values here, if the blood glucose is more than 500, it is suggestive of severe dehydration and the GFR might fall to 30 or 40% of the normal. And if the blood glucose is even more than 800, then the GFR would decrease to almost 50%. The monitoring of the child and repeating the investigations while giving the therapy is really important part in the management of DKA. It is important that you keep a keen eye on the baby, right? Certain things that we have to assess early, and there are certain things that we have to assess too early, certain things that we have to assess for early. Let's look at the brief account. How do you prepare a chart for diabetic ketoacidosis? Firstly comes the early measurements. Early, you have to take the vitals, heart rate, respiratory rate, BP, check the hydration status of the bacha. Also, do neurological examination thoroughly to look for any signs of cerebral edema. Right? You can ask the child about headache, any recurrence of vomiting, if the GCS is falling, if there is any restlessness or irritability, if there is increased drowsiness, if there is any incontinence. Also, the cranial nerve palsy, right? You have to look for any new onset palsy or any abnormal pupillary response. Also, in early monitoring status, you have to do input-output charting, that is fluid intake and urine output. This is to rule out whether the GFR is in normal range or not, right? We do input-output charting. Then early, you also have to measure how much of the insulin were administered and what was the capillary blood glucose values. Now, every 2 to 4 hours, there are certain investigations that you should send. These are feasible in certain settings, not feasible in others. Ideally, These have to be done every 2 to 4 hours, right? So these are electrolytes including sodium, potassium, calcium, phosphate and magnesium, blood urea levels, hematocrit, venous blood glucose, VBG to look for pH, bicarb and PCO2, urinary ketones, ECG. If the lab results of potassium are delayed, then you can do the ECG. Now there are certain calculations that you have to keep in mind while assessing the child's investigations. First of all, corrected sodium. As we all know that there is hyperglycemia, and due to hyperglycemia, what happens is there is increase in the intravascular volume, and this intravascular volume increase might cause a decrease in the serum sodium values. This is simply dilutional hyponatremia. Okay, so first of all you have to correct the sodium values. The sodium value will be corrected by add the measured sodium value plus 1.6 into glucose minus 100 divided by 100. Second of all, you have to confirm that this is ketoacidosis only by looking at the anion gap. Anion gap is a difference between unmeasured anions minus unmeasured cations, that is measured at sodium plus potassium minus all the anions, chloride plus bicarb. If it is high anion gap, then it is a strong indicator that it could be DK. Okay, now last but not least, you have to calculate the osmolality, because increased osmolality is also a feature because of the increased concentration of glucose in the intravascular fluid. Osmolality is calculated as twice into sodium plus potassium concentration plus glucose divided by 18 plus blood urea nitrogen divided by 2.8. Okay, the ABG is very important because we have to see that the acidosis that child is having is likely metabolic alone, and there is no superimposed infection on that. So a simple trick is there to know that the acidosis is likely metabolic alone if PCO2 is the last 2 numbers of the pH, or you can calculate it by Winter's formula, that is PCO2 is equal to 1.5 into bicarb plus 8 plus minus 2. So there's a brief review of how do we calculate whether the acid-base disorder is compensated fully, partially, what happens when there is respiratory acidosis, how the acute compensation takes place, how the chronic compensations take place. Similarly for respiratory alkalosis, this I think would require a different video because acid-based disorders have to be concentrated very well. So now coming back to diabetic ketoacidosis, also sometimes there is rise in TLC when you see the CBC of the child. Okay, so this leukocytosis with leftward shift is common in DK because there is release of cytokines and catecholamines, right? And this all doesn't necessarily indicate infection. Also, cultures have to be sent, blood culture sensitivity, urine culture sensitivity, and also chest x-ray is also to be done. All this is done to look out the foci of the infection. Also, if you find certain signs of cerebral edema, you can do a CT scan to evaluate the cerebral edema in these cases. Okay, to look for the signs of raised ICT. Also, you can do fundus examination for the same to look for papillary edema, right? Now, the major keys to the management are somewhat that you might have studied somewhere or seen in your emergency setting. So first of all, the key to the management, as soon as the child comes to you is very dehydrated, breathing rapidly, right? So initially we have to do water and salt replacement, followed by insulin therapy, followed by potassium replacement, followed by phosphate replacement. And after all this, we have to correct the metabolic acidosis and give bicarb therapy if required, monitor the child, and finally transit the child to subcutaneous insulin therapy from IV insulin, right? Along with this, don't forget that we have to prevent any of the complications of diabetes ketoacidosis, and also we have to prevent recurrent episodes of decay happening. First of all, replenishing the child's body water and salt deficit. First of all, to give the appropriate fluid, we have to calculate deficit. For mild to moderate cases, the deficit is around 30 to 50 ml per kg, but in severe cases, it's 50 to 100 ml per kg, right? We have to give initially fluid boluses. These fluid boluses are given by the child's condition, decided by the child's condition. If the child is in shock, then we straight away do the shock management, supportive management. We give 20 ml per kg of any isotonic solution. It may be 0.9% NS or ringel lactate, and this bolus has to be given very rapidly over 15 to 30 minutes. Also, if the child is not responding to this bolus, an additional bolus of 10 to 12 mg per kg and inotropes can be added to this. On the other hand, if the child is not in shock but the child is volume depleted, hypotensive, right, then we have to give around 10 to 20 ml per kg of 0.9% NS and isotonic solution, and this has to be given over 1 to 2 hours, right? Now this is the initial fluid resuscitation. Subsequent fluid management, you have to give the fluid therapy. It is very important, and this fluid therapy should be repeated again and again, initially over 4 to 6 hours. If the fall of blood glucose is more than 90 milligram per deciliter, then you have to switch the fluid to 5% dextrose and 0.5% NS. This is made by simply adding D10 plus NS in equal concentration, right? So we would get 5% D dextrose and 0.45% of NS. Okay. It is very important to note here that unlike in dehydration or acute gastroenteritis, where we replace the ongoing losses, the urinary losses replacement here is not required, because the initial rehydration that we give, that rapidly lowers the blood glucose levels, and thus they decrease the ongoing diuresis. So the urinary losses are significantly decreased. Now the rate of fluid administration. This fluid has to be given slowly over a period of 48 hours, and you have to obviously subtract the initial bolus dose, right? Except when the boluses were given for resuscitation, as and when the child was in shock-like condition. Okay, so now let's take an example. It is an example that is found in each and every book. They find a 10 kg boy, 10 kg male child, right, with severe decay. What is severe decay? pH less than 7.1 and bicarb less than 5 milligrams per liter, right? So a 10 kg boy with severe DKA, how would you manage the child? first of all, you have to calculate the maintenance fluid for 48 hours. As the boy is 10 kgs, so for one day, the maintenance fluid would be 1000, and for 2 days, that is 48 hours, it would definitely be 2000. And as the child is a patient with severe DKA, we consider that the child has 10% dehydration, so the fluid deficit would be 100 ml, 1000 ml, right? Initial bolus we gave the child as of considering it of shock of 200 ml, so the net would be 2800 ml over 74 hours, and the rate comes to be about of 59.5 milliliter per hour. Now after the fluid resuscitation comes the basic insulin therapy. This insulin administration is the one that reverses the metabolic derangements. Now many people are confused when to start the insulin therapy. Usually insulin therapy should be initiated after the volume expansion, that is, as soon as you give fluid replacement, within 1 to 2 hours of starting this replacement, insulin should be administered. In children, usually initially regular insulin is given, right? And we give low dose IV insulin therapy, that is 0.1 units per kg per hour. This is very low dose insulin therapy that we give in children. Now, how to prepare the children for easy calculations and everything? In 1 vial there is 40 international units, 40 units per ml, right? So you take 1 ml, that is equivalent to 40 units, and dilute it in 40 ml NS, and that would give you a solution with 1 unit per ml, right? And now the calculations would be very easy. For how long you have to give the therapy, IV insulin therapy, you have to give until there is resolution of ketoacidosis, that is, the urinary pH is more than 7.3, bicarb is more than 50, and there is closure of the anion gap, that is, the anion gap comes back to its normal value of 12 plus minus 2. Okay. Now, how to adjust the dosage based on blood glucose values? Now, by the therapy, the glucose is expected to fall at the rate of 36 to 90 milligram per deciliter per hour. And it is also very important to note that the blood glucose normalization occurs before the resolution of ketoacidosis. Okay, so the concentration of dextrose can be increased starting from 5 dextrose to 12 dextrose, as we have to maintain the blood glucose in the level of 150 to 200 milligram deciliter. When do we label it as insulin resistance? It is labeled as insulin resistance when the blood glucose of the child is not falling less than 70 milligram per deciliter in 1 hour, or the acidosis is not improving although the blood glucose is falling. Okay, so first of all, you don't label it insulin resistance straight away. You have to rule out any incorrect prescription by the doctor or incorrect preparation, or if and all there is extravasation from the cannula. Okay. Now, most important thing is, some people think that as long as the urine has ketones, we have to keep on giving IV insulin. That is not true. The clearance of urinary ketones is usually not an endpoint for the therapy and the IV insulin, right? the ketone dipsticks, because the ketone dipsticks, they principally detect acetoacetate, which continues to be detected even though the ketosis has resolved. And as the ketosis normalization is associated with the return of the elevated BHPA, that is beta hydroxybutyric acid to acetate ratio from 10:1 to 1:1. Now coming on to the potassium replacement, we all know that adding of potassium is essential because of the osmotic pull of the water. There is actual potassium deficit from the intracellular pool, right? And usually the potassium replacement starts with the insulin therapy. Potassium has to be added at the rate of 40 milligrams per liter, out of which 50% should be chloride and 50% should be phosphate. Now there are certain situations that you can face if the child is hypokalemic, that is the blood potassium levels are less than 3.5 milligrams per liter. Then you have to start potassium replacement even before starting the insulin therapy. But if the child is hyperkalemic, that is more than 5.5 milligrams per liter, then potassium replacement is deferred until appropriate urine output is documented. Once abnormal potassium values come, then you have to recheck the values every 1 to 2 hours. And the maximum rate of giving potassium is 0.5 milligrams per kg per hour. That comes around to be 80 milligrams per liter in the fluid. And if the hypokalemia persists despite of the replacement, then insulin infusion is reduced. Now coming on to the phosphate replacement, we all know that there is movement across the cell wall and osmotic diuresis in cases of diabetic ketoacidosis. So in this process, our total body phosphate is also depleted, right? But through various studies and clinical trials, it is seen that there is no clinical benefit of replacement of phosphate in these children. Okay, we call it as hypophosphatemia when the serum phosphate is less than 1 milligram per deciliter, right? Due to this hypophosphatemia, what all adverse effects happen to the tissue? These are, there will be oxygenation, that will lead to rhabdomyolysis or hemolytic anemia. So in these cases, phosphate replacement is given while closely monitoring the serum calcium levels. It is also important to note that in India, IV phosphate preparations are not readily available. So if and all he develops hypophosphatemia and requires this therapy, it would be very cumbersome to arrange for the same. Now finally coming to the correction of the metabolic acidosis and bicarb therapy. We all know that the acidosis in DKA is metabolic acidosis, and it resolves usually by administering fluids and giving insulin therapy, right? Also, by correcting the acidosis, some people question that why can't we give bicarb in this kind of metabolic acidosis like we usually do. We give bicarb correction, right? But here, giving this bicarb correction in a way would delay the correction of ketones, because bicarb can itself act as a substrate for the production of ketones by the liver, right? So there are various studies done where they administered bicarb to resolve the acidosis, but something bad only happened. This bicarb therapy is linked to very adverse outcomes, including increased risk of hypokalemia, hypernatremia, paradoxical worsening of the CNS acidosis, and very high risk of cerebral edema. So bicarb therapy is considered in children with cardiac dysfunction, that is secondary to profound acidosis, and in those that have very life-threatening hyperkalemia. Okay, the Bicarb therapy is now reserved for these cases only, when the child has cardiac dysfunction due to profound acidosis, and second, when there is any life-threatening hyperkalemia. You have to give bicarb at a very peculiar dose. You have to give it at 1 to 2 milligrams per kg, and it has to be given over 1 hour, and this bicarb is diluted with 0.45% NS. Now finally, as the blood glucose comes to the desired range, we have to switch the child from IV to subcutaneous insulin, right? Now this transition is only and only to be done when the oral fluids are introduced and a very substantial improvement is noticed, metabolic acidosis is corrected, and the patient indicates that there is a desire to eat, that is, his appetite has improved, right? And as these oral feeds are advanced, IV fluids are to be reduced, and IV insulin has to be transitioned to subcutaneous insulin, right? Most of the people ask when it is the time of switch, what is a good time when we can switch, right? Now, first of all, it depends upon the time duration before you're giving, right? So Lispro and Aspart, these are very rapidly acting insulins. These have to be given 15 to 30 minutes before the meals. Regular insulin has to be given 1 to 2 hours before the meals, and these subcutaneous insulin injections before transition, they should be given prior to stopping the insulin infusion. Okay, for example, basal insulin is given in the evening, and you stop the infusion in the morning, so that would be a good way to transit from IV insulin to subcutaneous insulin. Now coming on to the dose of insulin, the TDD, that is total daily dose in prepubertal babies and in pubertal babies. In prepubertal baby, it is 0.75 international units to 1 unit per kg per day. In case of pubertal, it's 1 to 1.2 units per kg per day. Before breakfast, you have to give in 2/3 part of this total daily dose, and the 1/3 goes after dinner. And out of this 2/3, 1/3 should be rapidly acting and 2/3 should be an intermediate acting insulin. Same before dinner, that constitutes 1/3 of the total daily dose. In this, 1/3 as rapid acting, 2/3 as intermediate acting. This way we have to prepare the formulation of insulin. Now comes the monitoring of blood sugar levels. Monitoring becomes very important, and you have to counsel the parents as well to monitor the blood glucose level at a frequent interval. So ideally, monitoring has to be done before every meal, that is before lunch, before breakfast, before dinner, and lastly but not the least at 2 a.m. when the child experiences maximum hypoglycemia state. Now last but not the least, we have to prevent the complications, right? So firstly, we need to know what all the complications that we can face. The most important one is hypoglycemia, hypokalemia, hyperchloremic acidosis. Also a very life-threatening complication of DKA, that is cerebral edema. Signs of dehydration, inadequate rehydration. Even it can also happen that dehydration can lead to some venous thrombosis, and that may be the cause why the child got so sick, right? So cerebral venous thrombosis. Any arrhythmia, we have to look at the ECG before even the potassium values come. We have to look whether this arrhythmia is secondary due to dyselectrolemia, or it is due to prolonged QT interval that is seen in hyperkalemia. Also, the other complications of decay could be pancreatitis. There could be any renal failure due to prerenal failure, or there can be certain rare complications. These rare complications are like decay, DVT, intestinal necrosis, rhabdomyolysis, pulmonary edema, and also certain infections like mucormycosis. Mucormycosis present as rhinocerebral and pulmonary involvement more and more. There is blackish eschar and blackish crust development. Now we have, as these are all the complications of DKA, now there are certain risk factors that warn us beforehand that this child might develop some or other of the complication of DKA. First of all, if the age of the child is less than 5 years. Second, if there is any new onset diabetes. Third, if there is prolonged duration of the DKA symptoms. And fourth is persistent and severe acidosis. And respiratory compensation leads to severe hypocapnia, right? And there are certain therapies also, as we have discussed earlier, that are very controversial and kept for reserve for very special cases. So the therapy associated risk factors include use of the bicarb, rapidly decreasing serum osmolality that might cause cerebral pontine myelonesis, or giving higher volume of fluids infused over in the first 4 hours, and if there is early administration of insulin within the first hour of the treatment. Now coming on to the features and the management of cerebral edema. Cerebral edema usually manifests about 4 to 12 hours after the starting of therapy. Okay, so as soon as you suspect cerebral edema, elevate the head end of the bed to about 30 degrees, administer the fluid, but this fluid administration rate should be reduced by 1/3. Airway has to be secured, and if warranted by deterioration in the sensorium, patient should be intubated and mechanically ventilated. And during ventilation, you have to do aggressive hyperventilation and keep the PCO2 less than 22. Last but not the least, you give intravenous mannitol to decrease the raised ICP. The usual dose of the mannitol is 0.5 to 1 gram per deciliter over 20 minutes. Or you can also give 0.3% NS, around 5 to 10 ml per kg over 30 minutes. If there is no response, then the dose is to be repeated between 30 minutes to 2 hours. And following institution of the therapy, the cranial CT is ordered to rule out any other treatable cause of neurological deterioration like thrombosis, hemorrhage, right? Now there are certain concepts that you should know. The first concept comes from the phosphate status. As we all know that in DKA there would be metabolic acidosis. This metabolic acidosis decreases the level of 2,3 BPG in the blood, and decrease in the level of 2,3 BPG will shift your oxygen dissociation curve to the left, leading to release of O2. That is also known as Bohr effect, right? Due to this release of O2, the end organs, the tissues won't get enough oxygen, and that will lead to muscle weakness, rhabdomyolysis, decrease in the cardiac contraction, and decrease in the respiratory muscle work, right? What happens in children is these children, acute little children with DKA, they repair their 2,3 DPG levels. Yes, they repair the 2,3 DPG levels. So they rapidly even out the phosphate supplementation, unlike the adult counterparts. Adults might have no such effort or energy to replenish this phosphate. This is the anion gap, we have already discussed about it, right? Now this is the consequences of ketoacidosis. The acidosis is the only one that leads to depression of the cardiac function, hyperventilation leading to Kussmaul's breathing. This hypocapnia causes cerebral vasoconstriction and decrease in the cerebral blood flow. Also, insulin deficiency causes increased prostaglandin synthesis in the adipose tissue. That's why there was pain, abdominal tenderness, distension, tachycardia, and flushed faces. Okay. Few pointers. We have already discussed the management of prevention of cerebral edema, but there are few precautionary points. The first is you have to use isotonic solution for hypovolemia correction. Also, very slowly give the replacement fluid. Third, you have to correct the acidemia and hyperglycemia, but these have to be done very gradually and steadily, right? Last but not the least, monitor all the electrolytes, especially the serum sodium. That's all for DKA. Let me know what all are your queries. These can be related to the diet that we advise, or it may be the administration, or maybe as to why this is happening. Or any other query. All of these are welcome. Keep studying and learning, right? I'll meet you soon with another useful video. And Chalo Pado is the series. Hope you're finding them useful. I'm Dr. Divya Madan signing off. You can DM me at my handle at the Dr. Journey on Instagram. Have a nice day. Warmth and hugs. Bye bye.